Bismillahirrahmanirrahim. So, this is the third lecture regarding the Treponema Pallidum, and in this lecture, we are going to study about the diagnosis, both the acquired and congenital syphilis, and the treatment of the syphilis. And this is the lecture third regarding Treponema Pallidum, as I have already discussed. So, let's start. So, the Treponema pallidum can be diagnosed in the lab mainly by the two ways, either by the microscopy or by the serological tests. And this serological test we will discuss may be specific or non-specific. First, talking about the microscopy. So, an important point, keep in mind that Treponema pallidum can't be seen on the gram stain as it is an atypical bacteria. So, we use the silver stain or the fluorescent antibody stain. If we use the silver stain, we can detect it by the normal microscope, light microscope. But if we use the fluorescent antibody stain, we have to either detect the Treponema pallidum by either the dark field microscopy or the immunofluorescent microscopy. And the spirochetes can be seen in the lesions either in the lesions of primary or secondary syphilis by the dark field or the immunofluorescence microscopy when we use this fluorescent antibody stain. This is the picture of the dark field microscopy in which we can see the fluorescent antibody staining of the Treponema pallidum. These are our Treponema pallidum showing blue-like color, and the fluorescent antibody staining in which we can see on the immunofluorescence microscopy as a green color Treponema pallidum. These all are the Treponema pallidum and the immunofluorescence microscopy and the fluorescent antibody staining. Now coming towards the serological tests, as we have already discussed that we can detect by microscopy or the serological tests. So talking about the serological tests, so they may be specific. Specific mean that we use the specific treponemal antigen derived from the Treponema pallidum, and the non-specific is also known as non-treponemal or the rapid plasma reagent test, because the antigen we use is not derived from the Treponema pallidum but is derived from the other sources. Was talking about the specific serological test, so as we have already discussed, we use a specific treponemal antigen, and thus they are more specific. The example are fluorescent treponemal antibody absorption tests, fluorescent treponemal antibody absorption test. The second one is Treponema pallidum hemagglutination test, and the third one is the Treponema pallidum micropipette hemagglutination tests. These are the three kind of tests which we can use specifically for the treponemal antigen to diagnose the Treponema pallidum. The other one is the non-specific test, in which we use a non-specific antigen like cardiolipin, which is derived from a beef, and this cardiolipin is react with the non-specific antibodies found by our bodies called the reagent antibodies, which is usually biochemically a mixture of IgM and the IgG. For example, the flocculation test like mineral disease research lab test or the rapid plasma reagent test, these both are the non-specific tests to diagnose the Treponema pallidum. But these non-specific tests can be positive or false negative. False positive occurs in a condition like autoimmune disease, leprosy, hepatitis B, and the infectious mononucleases. These are the conditions, some condition in which the non-specific test become false positive, and it becomes false negative in a condition like prozone phenomena due to the excess of antibody. But on dilution, it becomes positive. So they can be either false positive or false negative. So they are not so much sensitive tests. And how to distinguish between a specific and non-specific antibody? So in order to distinguish, the titer of the non-specific antibody decrease with the effective treatment. With effective treatment, the non-specific antibody titers decreases in contrast to a specific antibody which are positive for life. So if after treatment the titer remain positive or remain the same, so it means that they are specific antibody against the Treponema pallidum. Now, how to diagnose the congenital syphilis? So it is based on the findings that the infant has a high titer of antibody in venereal disease research lab test than the mother. If the infant have much more high titer of antibody on the venereal disease research lab test than the mother, then they are the diagnosed as positive. But if antibody declines with time, and it is false positive due to the crossing of maternal antibody through the placenta to fetus, and if it remains high, and we can diagnose that it is infective. For example, if we find high titer in the infant, then it is positive. But this positive may be false positive or really infected or positive. If the antibody declines when time, so it will prove that it is false positive, but it remains high, then it will prove that the fetus is in reality infected. Coming towards the treatment, so the primary and the secondary syphilis can be treated by giving a drug, benzathine penicillin. Benzathine penicillin has a half-life of about 2 to 3 weeks, and we give benzathine penicillin G because the Treponema pallidum growth is very slow. The growth of Treponema pallidum is very slow, so we use a drug which have a large half-life. The treatment after syphilis depends upon the symptoms. For example, if there are serious symptoms or boom are present, then we give 3 doses of benzathine penicillin G. But if it is but the CNS is involved, for example neurosyphilis, then we use the aqueous penicillin because they cross the blood-brain barrier. And if the patients are allergic to penicillin, then we used doxycycline, and for the pregnant women we use the penicillin. This is high yield. For pregnant women we use penicillin, and for the allergic patient we use the doxycycline. So that's all for today. Thank you.